Welcome everybody to this month's ECG series being conducted by EMKF and Daktari Online. My name is Nelson Nyamu. I'm a family physician and an EM physician.
My name is Grace. Good evening. I'm an emergency room nurse, and you're welcome to this series.
All right. So it's a 4-part series organized again by Emergency Medicine Kenya Foundation and Daktari Online. So today we are beginning with the approach to ECG interpretation, and being our first one, so the first question we're asking is, what's an ECG? And thereafter, what are the indications of doing an ECG? And what's the approach to interpreting an ECG?
Very true.
All right, and without further ado, Grace, what's an ECG?
Nelson, an ECG is a graphic representation of the electrical activity of the heart.
Mm-hmm.
Yes.
What do you mean by that? Those sound very physiological words.
That basically means that I think we all understand that there is electricity in the heart.
Yes.
Yeah, and that we basically call it impulse, electrical impulses.
Mm-hmm.
And normally it will be generated at the sinoatrial node. And you can see where the SA node is. It is conducted across the atria and to the AV node, where it is slowed down a little bit to allow the atria to contract completely, and then down to the bundle of His, and to the right and left bundle branches, all the way to the Purkinje fibers, so that then the heart, or rather the ventricles again can contract to push out the contents to the relative areas, as we all understand the blood flow through the heart.
All right, so what I'm understanding is, so an ECG is a graphical representation of all that electrical activity in the heart,
Very
right?
true. Very true.
Maybe now I'll just ask Grace, if you don't mind, maybe on this ECG now, could you track for us how this current is flowing and just explain to us what are all these deflections and lights?
Very good. So as all that is happening, we have tracings. We have said that it's a graph. We have a tracing over here, and that is the first one. It's called a P wave. A P wave is traced when the electrical activity is conducted from the SA node, sweeps across the atria to the AV node. So that positive deflection is what we call a P wave. And the ideal would be the normal heart rate, what we call a sinus rhythm, should always have a P wave, meaning that it is originating from the sinoatrial node, Dr. Nelson. After that, we have the impulse arrested for a very brief period of time at the AV node, and this allows the atria to contract completely, empty its contents into the ventricles, ready for the ventricles now again to contract again as the impulse is conducted across the bundle of His, right and left bundle branches, all the way to the Purkinje fibers. And when that event happens, that is when we get the QRS complex. Now, let me take you back a little, Dr. Nelson, and tell you that when we have the impulse delayed at the AV node, we trace this rather flat line between the P wave and the QRS complex, and it's called the PR segment. So that means it is on the isoelectric line. So the impulse is slowed down, is arrested, so no electrical activity is happening. A very brief period of time, you're going to see how long it should be in the normal ECG. And then after that, once the impulse is conducted down to the AV node, right and left bundle branches, all the way to the Purkinje fibers, that is when we trace the QRS complex. Right. So we get a P wave over here, which again is a positive deflection, and that is when our ventricles are relaxing or repolarizing, ready for the next action.
All right, so I can see one of the comments is that Grace was fast. Maybe it's because she's explaining it to me, I suppose, I guess, what I hope. And I think what Grace, and maybe just to recap, so we are saying that there is electrical activity inside the heart. And the first place that in a normal heart where the impulse starts is from the sinoatrial node, which is right here in the atria. And when the impulse is generated, it's transmitted across the atria through what we call the internodal, the atrial pathways. And as it's going through the atria, am I right, Grace? That's what now gives us this P wave right here.
That's very true, as the atria contracts.
As the atria is contracting.
Yeah.
And the other thing I understood from you is, so the current has flown from here, it has contracted, it has given us a P wave. It comes to the AV node, and you are saying there's a delay right here. The delay in the AV node, how is it reflected in the ECG?
The delay at the AV node is reflected as the PR segment, Dr. Nelson, which is a rather straight line, and it should be at the isoelectric line, meaning there is no like electrical activity that is recorded. We are at the isoelectric line, which is the flat line that you can appreciate over here. This is it. This distance at the end of this deflection, then to the beginning of the Q wave over here. Okay. This rather flat line over here, that would be the PR segment.
All right, so the current has started from the sinoatrial node, it has flown through the atria, it has caused the contraction, and it has given us a P wave. Now it's going to flow through the AV node, right? And we are saying there's a delay there. And that's what gives us this PR, what you're calling the segment.
Yes.
All right, and that's the flat line we are seeing here, which means there's no electrical activity recorded at that time.
Yes.
And after that, which is the AV node right here, we are saying the current now flows through the bundle of his, which is this proximal part, and thereafter quickly goes through the various bundle branches. I think at this point, it's useful to mention that we have this muscle right here, this whole muscle that you're seeing here. And this is what we call the interventricular septum. And for the depolarization of this interventricular septum, it usually comes from the left bundle branch. So the electricity, the impulse that depolarizes this comes from here. And this is what now Grace was telling us is responsible for this first deflection down here that is now called the Q wave, right? So the Q wave is because of the current flowing from the left bundle branch and coming to depolarize the interventricular septum. And it gives us this fast downward deflection after a P wave. And that's what now gives us the Q wave. And if I got you right now, Grace, so after that, now the current is flowing through the rest of the muscle, right? And that's what gives us the QRS complex. All right. And that is this one right here. So it gives us, so it's given us the Q, which is a fast downward deflection here. Then it gives us an R wave, which is this one here, right? Up and down. And if it comes below here, that's the S wave. And after that, do you want to tell us what next, Grace?
So after that, Dr. Nelson, the myocardium will be going back to its resting phase, or what we call repolarization. And then that is how we are going to trace our T wave over here. Yes. So that is what you're saying is that is our P, that is our PR segment. We have the QRS complex, okay? And then we have our T wave.
And then
so
that
makes a heartbeat.
And that's what makes a heartbeat, yes. The QRS, yes. the famous PQRS yes. wave.
T, yes.
All right. Yes. So again, maybe just to recap. So the P wave, and then the QRS complex, and then finally we have our T wave. Yeah. And we are saying that in between the P wave and the R wave, we have what we call the PR segment, which is when the current is flowing through the AV node. And finally, we have the ST segment, which is during when the ventricles are also contracting during that time, the ST segment, which is right here. And then finally, we have the T wave, which represents the ventricular depolarization. So I've seen someone asking on the chat, so it's ventricular depolarization. And then afterwards, after the output, we now finally have the resting phase, and then the cycle repeats again. So the current generated from the SA node gives us a P wave, flows through the AV node, gives us a Q, gives us the RS, the QRS complex. Again, finally, during the ventricular depolarization, the contraction. And then finally, we have the T wave, which is the ventricular repolarization. And that's an ECG, Grace?
Yes, that's an ECG.
All right. So it's the graphical representation
of the electrical activity in the heart.
All right. And maybe at this point, I want to ask you, Grace. You are a nurse, you are an emergency care nurse, and often you are seated at the triage area.
Yeah.
In which patients would you consider doing an ECG?
Thank you, Dr. Nelson. More often than not, we get to do ECGs on patients even before they get to see the doctor. And some of the complaints or signs and symptoms that the patient may present with for me to determine whether I need to do an ECG is chest pains. Any patients presenting to the ED with chest pains, because I would want to rule out or rule in a myocardial infarction. Any patients presenting with difficulties breathing, and this is because an ECG could give me insights or cues into what exactly is causing my patient's signs and symptoms. Like, for example, I'd be able to pick up some subtle signs of a PE. Patients presenting to us with syncopal attacks, fainting episodes. I want to ask myself, has the patient got an arrhythmia that is causing the patient not to get proper blood circulation to his vital organs, including the brain? We also get to do ECGs on patients for screening purposes mainly, our diabetic patients, our hypertensive patients, because we would want to get baseline information on what exactly is happening at the moment. And as we go on with medication or with treatment, we need to see the progression, disease progression. We also do it to evaluate treatment. So those patients who come with myocardial infarctions, they've been thrombolized or they've undergone a PCI. So we want to know how successful our treatment has been. Those are some of the indications of doing an ECG on a patient.
So I don't know whether I would be right to say this, Grace, but what I'm understanding is at any one time, I'm thinking that my patient could be having a cardiac cause of their symptoms or their complaints, then I would think of an ECG, right? And if it's, for example, like here now we are saying difficulty in breathing, if it's dyspnea, I'm wondering, could they be having a heart attack that's giving them, for example, pulmonary edema, causing them to have difficulty? That's what I'm understanding from you.
That is what I'm trying to say.
All right. Good.
So, Dr. Nelson.
Yes, Grace.
We need to go into approach. We need to approach how to interpret an ECG, and we need to know first of all, where was this ECG done? Yeah, we have already discussed the indications. Then from there, you want to look at an ECG, that representation that you have been given, and look at it and trace it to Dr. Nelson and not to Grace. That means that it has to be properly labeled with the patient's name and details that will say that this ECG was done on Nelson and not on Grace. You know what I'm saying? That is mainly for patient safety. So we are not giving Dr. Nelson treatment that is not his. It should have been given to Grace, you know? So patient safety is key. Then we want to know, is this ECG adequate? Yeah. So what about adequacy?
Yeah.
Is it well labeled with the patient's details that we have talked about? And then it should be complete, meaning there are no missing leads. Like, for example, when you look at this one, you appreciate a missing lead 5. So you'll not be able to comprehensively analyze the ECG and say this patient has this and not this. So it has to be adequate. When it comes to adequacy, again, it has to be clear, meaning it doesn't have artifacts. You can appreciate artifacts on this ECG. These are too much noise, as it were. Okay. If you compare this segment with this segment, this is a lot better. But this one is too noisy. You may not be able to appreciate or to analyze it properly.
But let me ask you, Grace, because I always see these kind of ECGs and they make life hard in terms of interpretation. So if I see a lead with a lot of this kind of noise or artifacts, what could be some of the potential causes and how can I try and get a better quality ECG?
Good. Some of the causes of artifacts on an ECG tracing will be patient movement. So you may have to tell your patient to stay still for a few seconds as you run the ECG. If your patient is very hairy, you may have to clip that hair a little bit. Do not shave. Infection control. You need to clip the hair, and that will be only on the areas you are applying your leads. So that you get a clearer ECG tracing. If your patient has electronics in the pockets, again, that may interfere with the tracing, and they may need to remove them and put them aside for a short while.
All right. So Just to go back, Grace. So I think we've said one is to actually get to know why we are doing the ECG, and that's an indication of the ECG. And you've talked about labeling and making sure we have identified the ECG adequately, and finally adequacy. I think we are slowly going into an approach to interpreting an ECG, and I think I was sharing with you, Grace. I work in the ED department, and I'll tell you, ECGs can be very humbling.
Very true, I agree.
Especially for me, when you bring an ECG, the first instinct is to say, I don't know what's going on, right? But for me, I think I've come to find that having a systemic approach to an ECG is what safeguards me as a doctor to make sure that I do not overlook something that could be going on in the patient's heart or the electrical conducting system, as it were. And the system, and I think that's what we are going to go through in the rest of the presentation, is asking ourselves, what's the rate of the ECG? Or sorry, what's the heart rate of the patient? What's the rhythm? What's the axis? And we'll discuss about axis when we get there. And then going through the various components of the ECG. So the waves, the intervals, and the segments. And finally asking ourselves something about what we call the contiguous leads. And then finally analyzing all this information and asking myself, what could be going on with my patient, right? Sure. Grace, let me just open an ECG for you. How would you analyze the rate in this patient? And as you're answering this, because I think you do this all the time, just tell us what's the utility of this information down here. So the speed, and I can also see something on the limb. Just tell us something about this.
So, Dr. Nelson, an ECG caliper, standard calibration, it traces at a speed of 25 millimeters per second. So the ECG paper, the x-axis, this is the x-axis.
This one here.
Yes, the x-axis represents time. So I've just said that an ECG caliper traces at 25 millimeters per second. This is it, okay? In terms of the y-axis, this is about millivolts, millimeters per millivolt, and it traces at 10 millimeters per millivolt. Okay, that is x. No, that is the y. That is the
that's the x.
Yes.
So let me ask. For example, in this tracing, it means the machine was set at 25, and for that's for the speed. Yes. And the voltage was set at 10 millimole. Are there times that these settings can change? Yes, there are times that these settings can change, and it is your responsibility as an individual to be sure that your machine is set at this standard calibration. Okay. Yes. All right. So with that in mind, Dr. Nelson, if you want to evaluate the patient's heart rate from an ECG, with the common understanding that this machine is tracing at 25 millimeters per second, then you ask yourself, then how many millimeters will I have traced in a minute? So we know that there are 60 seconds in a minute. So that would be 25 times 60. I'll give you the answer because we had discussed this. So 25 times 60 is 1500. 1500. Okay. Very good. Yeah. So now you take the interval between one R interval to the next. That is if your rhythm is regular. All right. So you count the number of small boxes therein, because one small box represents 25 millimeters. Okay. Okay. So you want to get the rate by dividing the number of small boxes therein with 1500. So sorry, Grace. I love maths, but ECG maths can be confusing. So you are telling me at a speed of 25 millimeters per second, ideally, if we were to run this paper for a whole minute, it will have covered 1500 small boxes. Precisely. That's what we are saying. Yes. All right. And so if I want to find the rate for this patient, ideally I would have run this paper for a whole minute, right? Yes. Yes. Which sometimes may not be economical. Precisely, right? Yeah. So if I'm to estimate the speed or the rate for this patient, so the rate, thank you, the rate. So you are telling me I count the number of small boxes between one heartbeat to another, or find if it's between the R wave here, I find the number of small boxes and I divide by 1500. All right. I know that's one method. There's another one where people use big boxes, 300. Tell me something about that.
So the one for big boxes, I hope we can appreciate the ECG paper, or we have an access to an ECG paper so that we are also like looking against it. If you look at this ECG paper over here, we have big boxes. That's a big box. And in this big box, there are 5 small boxes. Okay. So that means that if I was to work with the number of big boxes as opposed to the small boxes, I would just say 1500 divide by 5. Okay, that would be 300.
Okay.
So then I'm saying the number of big boxes between one heartbeat to the next one for our regular rhythms. Now I divide 300 by the number of big boxes. Yes.
So let me, for example, using this tracing right here. So if I take this, and I'm taking this just because I can see it's very close to one big box. So for example, if I count, so that's 1, that's 2, that's 3, that's 4, that's 5. So if I do 300 divided by 5, that gives me 60.
A heart rate of 60.
So that's for this particular patient. Yeah. I think to me that's easy. Yeah, as opposed to using the 1500, although the 1500, I agree with you, will probably give us a more accurate rate for this patient. Now, you've emphasized that if it is a regular rhythm, tell me, what if this patient has an irregular rhythm? How do I calculate the rate?
Now, if our patient has an irregular rhythm, and you're going to check, or rather to evaluate for regularity and irregularity, then you take this as a 6-second strip, okay? And so you count the number of QRS complexes therein and you multiply by 10 to make your 60 seconds.
Do you want to do this for us right here for this patient?
So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So that you multiply by 6, and you get your heart rate at 60.
All right. So
the number of QRS complexes therein, and you multiply that by 6.
So what I'm understanding is this whole tracing runs for 10 seconds, right?
Yes.
So if I'm to get the rate, then I multiply by 6.
By 6.
Yes.
So that you can get your 60 seconds.
The 60 seconds.
Yes.
All right. So just to recap, so if you want to calculate the rate, so you can divide the small boxes in between 1 beat by 1500. So 1500 divided by the number of small boxes, or you can do the 300 divided by the number of big boxes. Yes. The other option is to calculate the number of the beats that are therein. Yes. And remember that this strip runs for 10 seconds, right? Yes. And then you multiply the number. So like for this patient has 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then you multiply that by 6. All right, good. Now, so we've done the rate, and I think the next thing is to go through what we call a rhythm. And maybe I'll take this, Grace, and you can add a few comments. So by rhythm is, we are asking ourselves, one, where did the impulse originate from? Did it originate from the sinoatrial node, or did it come from somewhere else, right? And we're asking ourselves, is the current flowing from the atria and then down to the ventricles? And remember, in this today's seminar, we are doing just the basic normal ECGs. As we go on, we'll build up on this content. So a normal ECG sinus rhythm, which means it's coming from the sinoatrial node, we should have a P wave followed by a QRS complex.
Very true.
Right?
Every P wave should be followed by a QRS complex. And that is to mean that the impulse that was generated from the sinoatrial node has been spread across the atria, giving us a P wave, and it has been spread across to the AV node, bundle of his, all the way down to give us the QRS.
The QRS.
Yes.
And that's now what we call sinus. Sinus rhythm, meaning it's coming from the sinoatrial node, right? Yeah. All right. Good.
Let me ask you, Dr.
Yeah, please ask.
Are you telling me that this impulse can be generated from elsewhere other than the SA node?
As a matter of fact, yes, Grace. Actually, electrical cardiac physiology, they say every part of the cardiac muscle can actually generate a cardiac impulse. And so in a normal heart, we have the sinoatrial node that normally generates at a rate of around 60 to 80. And what it does, therefore, is it does what we call an overdrive. So it suppresses the rest of the other parts of the heart in a way that they cannot generate the beat. But to answer your question, yes, a current can originate from the sinoatrial node, which is the atria. It can originate from the AV node, or what sometimes we call the junctional rhythms. It can originate also from the ventricles, what we call now a ventricular rhythm. And therefore, that's why it's useful. And as we build on this, we'll find if it's not a sinus rhythm, then the question is, what rhythm is it? And could this be giving my patients symptoms? I don't know. Do you want to add something to that, Grace?
I think
that's clear. So we've done the rate, so which is, we've seen it is 60, and we are happy with 60. And why are we happy? Because a normal rhythm heart rate should be at least 60 to 100, right? That's the normal heart rate. And then we've done our rhythm. And at rhythm, Grace, I think I forgot to mention, it's useful to confirm that it is regular.
Very true.
And do you want to talk about that?
Yes, sometimes you get irregular rhythms, and it's very critical that you get to know whether your rhythm is regular or irregular. And how we get to know that is basically by tracing. There's no science here, just tracing between beats. Could possibly take an RR interval of 2 beats. Then with that, you trace against the two other RRs intervals that are after that. And if the markings are falling in place, then you say your ECG is regular.
Okay.
If they do not fall in place, they are disparities, then you say that your ECG rhythm is irregular.
Right. Yeah. And for today, we are doing basic ECG, which means if it's a regular rhythm, we are happy. But as we build on this content, we'll find that with irregular rhythms, we're asking ourselves, could this be contributing towards our patient's pathology? So we've done the rate, we've done the rhythm. The next one is to have a look at the axis. Do you want to have a go at this, please? Or you want me to? All right, so you give it. All right. So the axis is essentially looking at the overall direction of the electrical current in the heart, and the electrical current flows towards the parts of the heart that have the most muscle, which tends to be the left ventricle. So without making it very difficult, is in a normal axis, which means that the direction of the current is towards the left side. And if you are to use degrees, this would be around 30 to 60 degrees. We should have lead 1. And I think in the next presentation, we'll review this, because I can also see comments on the various leads, is that we should have the QRS complex in lead 1 being predominantly positive. That's there. And also we should have the QRS complex in lead 2 also being predominantly positive. And that's what we expect to be a normal rhythm. Normal axis, yes, normal axis. Sorry for that.
Let me interrupt.
Yes, please, go ahead.
Could you please tell us what you mean by saying negative? I mean positive.
So by positive, so there's a concept you brought up, Grace, and that's a concept of an isoelectric line. So isoelectric line is when there's no electrical activity that is being recorded by the machine. And for example, this is our isoelectric line right here. But more accurately, if we were to get the isoelectric line, we normally use what we call the TP segment, which means at the end of your T wave, which is, for example, somewhere here, and let me use this one. So at the end of somewhere here, which is the end of the T wave and the P wave, so that gives us our isoelectric line. And we can use that line to judge whether the wave is positive or whether the wave is negative. And by positive, what do we mean? It's simple, that the wave is moving upwards. And what that means is that the current in that lead is moving towards that electrode. Let me just put it like that. And if it's a negative deflection, for example, if I come here to V2, so this is negative, and this is normal because this is what we expect, is that in a normal, so here, I would say this is a negative deflection. The QRS is predominantly negative. And so that's, to answer your question, that's what we mean. So whether it's a predominantly positive or predominantly negative, you have to use your isoelectric line as the reference.
Thank you.
Yeah, and now we are saying back to our axis that in lead 1 and in lead 2, they should be predominantly upward facing. Now, why is this useful? Why is this useful, Chris?
This is useful in telling us the direction of the current flow. And if then you expect that this should be a normal axis, and now you find that it is, you expect positive and it is negative, then again, it is telling you that there is something wrong with this electrical flow.
Okay.
So now that you're doing the normals, when you come to doing the abnormals, then you'll be able to pick.
What do you answer? Grace, what next do we do?
Now, having looked at those, so to say, global analysis, then you want to go and look at wave for wave, interval for interval, segment for segment. Okay, so now we have talked about waves. What is a wave? A wave will be a positive or negative deflection from the isoelectric line. So this is our P wave, it is positive. That is our QRS complex. And then we have our T wave. So these are the three waves we have. We have our P wave, we have the QRS complex, and we have the T wave. So any deflection, be it negative, be it positive from the isoelectric line. So we'll start with analyzing our P wave, Dr. Nelson.
Okay.
And we have already said what it is. I don't know whether you want us to repeat. It is the tracing that we get when the impulse that is generated from the SA node is conducted through the atria to the AV node, making our atria to contract or to depolarize. We trace a P wave, and this is it. That's a P wave, that's a P wave, and that's a P wave. There is a P wave with every QRS complex. Now, what are the characteristics of a normal P wave, Dr. Nelson?
All right. So, Grace, I had read, so I know the answer. So a normal P wave. So one is we are assessing that whether it's, and stay tuned, because as we'll be discussing, we'll also now touch on the pathologies. So we expect a smooth upward deflection of the P wave. Now, I must, however, say that in some leads, it's normal to expect a negative P wave. And one good example is in the AVR, the one that we are seeing here. So in AVR, we're expecting a negative P wave, as well as sometimes in V1, we're also expecting a negative P wave. And so, and that's a normal morphology of a P wave for a normal ECG. Now, may I add now, so when we are now thinking, because remember we are saying, my patient came with chest pain or maybe came with syncope, I'm doing an ECG, is there an issue with atrial depolarization? That's what we're asking, and that's the info we want to get. So like for this patient now, we find it's a normal P wave. How do you know it's normal? One, it's upward facing in the leads where it should be upward facing, and it's downward facing in the leads where it should be downward facing. Sure. And that's what a normal P wave is for us. And we are happy with that, right?
Yes, we're happy with that. Okay. And especially so because we also appreciate that it is not more than 3 small boxes wide, right? It should not be more than 3 small boxes wide, and it should not be more than 2 small boxes tall.
Thank you.
Yeah?
Yes.
So it's a normal P wave.
All right.
So from there, we analyze our PR segments, which is the small flat line between the end of P and the beginning of our QRS complex. We already said that this is where the impulse is delayed at the AV node. If you were to take the PR segment, it should not be more than 2 small boxes wide. Okay, should not be more than 2 small boxes. Yeah, let me say wide. Then there is something else that is called an interval.
Do you want to tell us what that is? Sure. We are introducing new terms.
Yes. So a PR interval or any interval will be a wave and the segment in front of it.
Okay.
So a PR interval now will be at the beginning of the P wave to the end of the PR segment. So an interval is a wave and the segment that follows it.
All right.
So now for our PR segment, it represents the electrical activity as it happens above the ventricles.
PR interval.
PR interval.
Okay. All right.
Yeah. The electrical activity as it happens above the ventricles.
Okay.
So from the time the impulse is fired at the SA node to the time it is conducted to the AV node, that is the PR interval.
Okay.
Now, how long should it be? It should not be more than 5 small boxes.
Okay.
3 to 5 small boxes would be the norm. So looking at our ECG, we have a normal PR segment. Now, Dr. Nelson, what do you think would be going through your mind if you got a slightly prolonged PR interval or a very prolonged PR interval?
All right. So you are hinting on to our next presentation, which is the various pathologies that we can find from an ECG. So a prolonged PR interval, which is from the beginning of the P wave to the R wave, we have said should not be more than 5 small boxes, right? If it's longer than that, I'm wondering, could this patient be having blocks? So either 1st degree, 2nd degree, 3rd degree, and I'm wondering, could this be contributing towards my patient's symptoms? All right, good. After the PR interval, what next, Grace?
We have the QRS complex. It is a combination of the Q wave, R wave, and the S wave. It happens in such a short period of time that we cannot analyze wave for wave, so we take it as a complex. Please tell us something about it.
All right, so remember we talked about the QRS complex. So the Q is the first downward deflection after the P wave. So for example, here, this small deflection you're saying here might constitute a Q wave. And then afterwards, the upward deflection, that's the R wave. And then the downward deflection after that is the S wave. So that gives us the Q down, R up, the S wave complex. And it represents the ventricular depolarization. Now, we are looking at a normal ECG. And yes, we've seen the comment that we should zoom in on this, and we've noted that. But also if you're using a phone, if you zoom in, if you pinch and zoom in, it will also be clear on your end. But we are saying, Grace, that a normal QRS complex, one, we are assessing the length of it. And that is, it should not be more than 3 small boxes, right? And we are saying with that, that's a normal QRS. If it's longer than that, I'm starting to wonder, could there be a pathology with this? For example, could there be a bundle branch block? Could this patient be having medications that are prolonging the QRS complex? And could they be giving my patient any symptomatology? I don't know what you want to address on that.
Yeah, the QRS complex should not be more than 3 small boxes wide. And in terms of time, that should not be more than 0.12 seconds. So if it is a little wider, then you're thinking, is it a ventricular rhythm? Is the impulse originating from the ventricles? So then am I able to tie what is happening, what I'm seeing with my patient's symptomatology? And what do I need to do about it?
All right. May I also add, so when you're also looking at the Q wave, so the Q waves should not be more than 2 small boxes. Otherwise, that now comprise what we call pathological Q waves. And we will touch on this as we go on. Now, at this juncture as well, it's good to mention about something that we call the R wave progression. And the best example is this. So if you look at our V1, the R wave here is downward facing. And it's downward facing because from where the V1, the electrode is, the electrical current will be flowing away from V1. And it's flowing towards the left ventricle predominantly. And that's why you will have a very deep S wave here. Actually, that's a term. Sorry, I'd said it. So we have a deep S wave here. Now, and a tiny R wave here. Normally what we expect is that we are expecting, as we are moving from V1, which is towards the right side parasternal area, towards V6, which is in the mid-axillary area, that our R wave predominantly becomes bigger. So it becomes positive. So small R wave here, then it's slowly becoming bigger for this patient. And this is ideally what we would expect. Otherwise, this is something, if you don't see a normal R wave progression, for us as primary caregivers, then we flag ourselves and ask, could this also be contributing towards the pathology of what the patient has presented with? So to summarize at the QRS, so one, we've looked at, are there pathological Q waves? We've said they shouldn't be more than 2 small boxes. We've then looked at our QRS complex, and we've said it should not be wider than 3 small boxes. And if it's wider, we wonder what's going on, what's the diagnosis? And we've also looked at our R wave progression as it's moving across the anterior chest leads. So Grace, we've done our, just to recap, our rate, our rhythm, our axis. We've looked at our P waves, PR segment, PR interval, QRS complex. What next?
Now we want to look at the ST segment, which is the distance between the S wave and the beginning of the T wave. Okay, that is mainly what will guide us in determining whether our patient has a myocardial infarction or otherwise. So it should basically not be more than 2 small boxes or 2 millimeters above the J point. Would you kindly show us what we mean by the J point?
All right, Grace. So what Grace is mentioning is the transition point from an S wave. Let me use V3, for example. So we have our R wave, we have our S wave, and we have the point at which we have the transition from the S wave to now our T segment. Am I correct? Yeah. Sorry, our ST segment. But just to allude on the T wave, so again, the T wave is similar in assessing and asking ourselves, is it upright where it should be upright? Is it downward facing where it should be downward facing? And besides that, we're also asking ourselves whether it's upward, downward, that's what we've asked. And we're asking ourselves, are there other changes? For example, is it peaked? Is it taller than an R wave, for example? Are they broader than they should be expected? And what's the shape of the T wave? By the shape of the T wave is, we normally don't expect the T wave to be biphasic. That means it's going up and then coming down. We expect it to be predominantly upward alone. We don't expect it to go up and down. And alluding to our next presentation is that some of these aberrances or deviation from the normal are what could guide us towards making a diagnosis. So for example, a T wave that is downward facing, or what we call inverted T waves, is not normal. And we ask ourselves what could be going on. A T wave that is broader than we expect, or a T wave that is peaked, what we call peaked T waves, or what we call broad-based tall T waves, hyperacute T waves. Those are not normal. And we ask ourselves, could this be contributing towards the diagnosis of our patient? So in summary, so we've discussed our QRS complex. We've looked at our ST segment and asked ourselves, is it on the isoelectric line? Is it elevated than we expect? Which is what now would happen, for example, in what we call an ST elevation, myocardial infarction, and other differentials, I have to say. Or is it depressed, as might occur, for example, in myocardial ischemia? And what we are teaching today, or what we are going through, is to say that if the ST segment is not where it should be, you ask yourselves, as the one doing the ECG, interpreting the ECG, is this contributing towards the pathology of my patient? Now, we've touched on our T wave, and we've asked ourselves, is the T wave upward where it should be upward? Is it downward where it should be downward? And if that's not the case, is this contributing towards the pathology of my patient? We've asked ourselves about the morphology of the T wave. Is it what we call a biphasic T wave, the shape of it? And therefore, could that be contributing towards the pathology of my patient? And after that, the next question is, so we've gone through our rate, our rhythm, our axis. We've gone through our P wave, PR interval, QRS complex, the ST segment, the T wave. And we are almost at the end of it. And finally, we're asking ourselves, are there any other additional ways that we need to be aware of? And a good example of additional ways is, for example, something like what we call UAs, but without which we'll discuss in our the next seminar. Grace, you want to add something?
Yes, I would want to add something as we still continue sorting out our technology. Now, having looked at the ECG, different waves, different morphologies, different segments, you'd also want to ask yourself a question about what leads am I looking at that are representative of which part of the heart? In other words, contiguous leads. So then if I'm appreciating any changes on lead 1, 2, 3, or whatever leads they are, then what are we saying? Are we saying that, okay, which part of the myocardium or which part of the heart is affected by these changes? So basically, what are we saying? We need to know contiguous leads. So yeah, we're talking about contiguous leads. So if I ever appreciated any changes, any changes whatsoever on the ECG in leads 2, 3, and AVF, then I know I'm looking at the inferior part of the heart, of the myocardium. And in this case, I don't have to appreciate changes on all the 3 of them, but at least 2 of the leads that represent one part of the heart. Now, if I appreciate any changes on leads V1 and V2, then I know I'm looking at the septal part of the heart. If I see any changes on leads V3, V4, that will be the anterior part of the heart. If I appreciate any changes on leads V5, V6, AVL, and lead 1, then I know I'm looking at the lateral part of the heart. So that is also very key, so that you have an instinct, you have an insight of which part of the myocardium, which part of the heart is affected. That may also actually help you to outline your management. Nelson?
Oh yeah, thank you, Grace, for that. And again, apologies for the technical glitch. So what Grace has just touched on is, so you've been seeing some changes on the ECG, right? The next question is to ask yourself, are these changes because of a certain part of the heart? Is it the lateral side? Is it the anterior part? Is it the inferior part? And the beauty is that the various leads of an ECG, they actually map out the different areas of the left ventricle. So we have the inferior part of the left ventricle, 2, 3, and AVF. So if there are changes that are occurring on either on these 3 leads, then you know it's something that is happening on the inferior side of the heart. If it's something that is happening on V1, V2, V3, V4, then you already know this is something happening on the anteroseptal part of the heart. And that makes you think about, possibly that's a diagnosis. If you look at the leads which look at the lateral side of the left ventricle, that's lead 1, lead AVL, lead V5, and lead V6. Then those are looking at the lateral side of the heart. So we are saying you've seen changes. The next question is, are the changes being observed in one particular part of the heart, which then can again reinforce your diagnosis. So in summary, Grace, well, I don't know, what's your take? And I love this conversation because it's for primary care, it's for emergency care. You are a nurse, I'm a doctor. You from a nursing perspective, what's your summary on this?
From a nurse's perspective, Dr. Nelson, I think this is very key. It's a must know. Mm-hmm. I should be able to tell a normal ECG from an abnormal ECG. Mm-hmm. And my objective here is to be able to know or to tell whether the signs my patient is presenting with are because of what I'm seeing on the ECG, or what I'm seeing on the ECG is what is giving my patient signs and symptoms. Mm-hmm. Basically, is this going to kill my patient? Right. Do I need to do something now as I get a cardiologist to come and sort out those bigger issues? Mm-hmm. Am I going to just do nothing? Mm-hmm. It's nothing that is going to harm my patient right now. Mm-hmm. I don't need to do anything. I just need to refer my patient to a cardiologist. Mm-hmm. So I need to pick out a rhythm. I need to pick out those abnormal rhythms that are going to kill my patient now and be able to do something about it. And that way, I will only be able to do that if I know what the normal is. Yeah, pick out the abnormal from the normal and do something about it to save your patient.
All right, so more on the triaging. I think the summary from my bit is always have a sequence of following, of interpreting an ECG. And if you have one that works for you, that's fine. But like what you've just gone through, if we just stick to this kind of a rhythm, we are most likely going to pick up any pathologies that our patient is presenting with, and we will not be anchored onto what is shouting at us and missing the rest. So just following that sequence, do you know what's the setting of doing the ECG? Because an ECG for Grace might be very different for me because of the different clinical presentation. Afterwards is the ECG I'm reading, is it for my patient or is it someone else? So is it well labeled? And after that, going through the various sequence, the rate, the rhythm, the axis, the waves, the intervals, and asking ourselves about the regions of the heart and whether they are being more affected. I think that was our presentation, and thanks for hanging on despite the technical glitch. So I think we go to questions and answers. We'll look at Lily. I think after the glitch, we could have lost a number of what's going on. So I think I'll start from the start. I think there were issues about the screen not being seen. I think we sorted that out. Let me go down. Suhail Juma saying you guys made ECG reading easy, much appreciated. We appreciate that. Do we have offline version of the seminar? Yes. So in the Emergency Medicine Kenya Foundation, we have in the YouTube site, we have all these uploaded as well. Great presentation, thank you. In the next section, kindly touch on axis deviation. Wasn't clear on axis. Lead placement of the chest.
Next week.
Yes, Grace. So next week, we already have our work cut out. But you'll note that today we wanted to focus on the normal and a way to read an ECG. Now, next week, we will delve into more of these details. Let me see. Kindly share slides. Yes, they will be accessible. Repeat the YouTube channel, please. The Emergency Medicine Kenya Foundation. So there's a whole playlist of the various other talks that have been done. A bit recap on J-Point. I think we went through that when that was posted. I need the recording. Yes, it will be available. Please post link. Yes, we will share this with you. Yes, CPD points are being offered by Daktari online. So you will be able to receive them once you signed up.
There's a question, Dr. Nelson.
Yes, please, Grace, go ahead.
Yes. Question from one of the participants. Let's go back to the question and answer section. I think he was asking, why are we multiplying? I think by 10 or by 6. So he has a question about the multiplication about the irregular rhythms.
Okay, you want to address that, Grace?
Because of the calibration we talked about, 25 millimeters per second, it is assumed that every ECG strip is a 6-second strip. Okay, so we do heart rates per minute. So if you have only recorded for 6 seconds, to make a minute, we multiply by 10 to make a minute. Okay. So we count the number of heartbeats that are traced in these 6 seconds, and then we multiply by 10 to make a minute.
All right. I hope that's clear, and thanks for clarifying that. Mohammed Ahmed is saying always simple during class, but totally different when you have the ECG report. Yes, totally. It always happens to me. I won't lie about that. Will there be a difference in P wave if current originates in atrium rather than the SA node? Good question, Twalib Abdullah. And we'll tackle that on the next presentation. But it's useful to note that the various conditions that can give us abnormalities in the P wave include things such as ectopic atriopics, multifocal atrial tachycardia. We're also looking at atrial fibrillation, which we even don't discern P waves. We are looking at atrial flutter, and we'll be able to go through this all the time. Next time, that is. All right, so I can see a lot of questions on the J point. So J point is the transition point from the S wave to the ST segment. And do you have an addition on this, Chris, on the J point?
Not really, but it is sharply defined. So you should be able to appreciate it. Maybe next week we should be able to come with an ECG that is clearly showing our J points.
Okay. Yeah. So in the AVR, right, and we'll touch on this in the next presentation, they usually say the AVR is the opposite mirror reflection of the lateral leads. So here we would expect a negatively deflected T wave. But in all these other areas, if you are having unusual T waves, and remember we are primary care doctors, we're asking ourselves, is this something that I want to escalate to my senior doctor or the cardiologist? So we picked a number of issues with T waves. One, the direction in which they are facing. So for example, if here you start seeing it's not upward anymore, it's downward facing, then you ask yourself what's going on. If you find this T wave is so upward facing, and in this presentation, we did not put a lot of pathology because that was not the focus. We'll do that next time. But peaked T waves, or what we call tall and broad-based T waves, those are pathological. And as primary caregivers, we have to ask ourselves what is going on. Further to that, we're also talking about, which I think we'll discuss in week 3, which is things to do with what we say the winter T waves, biphasic T waves. And all those are pathological. But for today, we are saying a T wave should be upward facing in the leads. And if it's downward facing, you're asking yourself, what's going on? Normally in the AVR, you would expect a downward facing T wave.
Awesome.
All right. All right. So Lucy Chipchumba saying you didn't add indication. So we only highlighted very few indications. There are many indications for us to do ECGs. And the list can keep on growing on. It's screening for pre-surgery. I totally agree. Dr. Kishkumar Devlak, does coronary stenting change ST depression segment? Absolutely. And that's yes. So after revascularization, they're always you're expecting the T wave changes and all, but that's not for today.